Imagine for a moment, you're a detective, but not the noir trench coat wearing, standing under a street lamp. You're wearing scrubs.
Right, a clinical detective.
Exactly. So you walk into a hospital room, the fluorescent lights are humming, and you see a patient. And immediately, before you even say hello, you see the clues.
It really does start the second you walk in the door.
It does. You see the jaundice. Their skin has that telltale yellow tint, the whites of their eyes.
The sclera.
Right, the sclera are icroteric. You walk over, you introduce yourself, and ask them to lie back. You place your hand on their abdomen, specifically the right hypochondrium, so right under the ribs, and you feel something. It's a lump. It's smooth. It's distinct. And interestingly, it's non-tender. It doesn't hurt them when you press on it.
That's the key right there.
Right.
Yeah.
Now, without waiting for a blood test or a scan, your brain has to make a leap, a deduction. Where does your mind go?
Malignancy until proven otherwise.
That is immediate, isn't it? Like, that isn't a let's wait and see. That is a red alert.
It absolutely is. And that specific deduction, that mental leap from a smooth, painless lump in a jaundiced patient directly to the suspicion of cancer is the essence of what we are deep diving into today. It is one of the most famous eponyms in surgery, Courvoisier's law.
I love this topic because it sounds like we're just going to talk about a dusty old medical rule from the 1800s, but we're actually talking about logic. We're talking about physics.
Exactly. We are looking at source material today that calls this surgical thinking.
Yeah.
The goal isn't to just memorize a fact for a board exam so you can bubble and see and move on. It's to move from rote memorization to understanding the mechanics of why the body behaves the way it does. We want to get to that consultant level understanding where anatomy and logic sort of merge.
So our mission today is to really unpack the detective logic behind the physical exam. We want to understand why that lump is there, and more importantly, why it means what it means. Let's start with the law itself, because I feel like a lot of people memorize a shorthand version of this that might actually be wrong. Is the law simply, if you feel the gallbladder, it's cancer?
That is the common misconception, and honestly, it's a dangerous one because it lacks precision.
Right.
If you look at the actual definition and the way Ludwig Courvoisier actually phrased it in 1890, precision matters. Courvoisier's law states that in a patient with obstructive jaundice, a palpable gallbladder is unlikely to be due to gallstones.
Okay, let's pause on that for a second. It doesn't say it is definitely cancer. It says it is unlikely to be stones.
Correct. And that distinction is huge. It's a statement about probability and anatomical history. It rules out a specific cause stones more than it rules in a specific cancer, although cancer becomes the leading remaining suspect by default. It's telling you what isn't happening inside that abdomen.
So to really get this, we have to understand the why. Why wouldn't a gallstone cause a big, palpable gallbladder? I mean, think about basic plumbing. If I plug a garden hose with a rock, the hose swells up behind the rock, right?
Right.
Why doesn't the gallbladder do the same thing when a stone blocks it?
Well, that is the intuitive thought, and it makes sense if you think of the body as a brand new machine. But the body has a history. We have to look at the timeline. This is where the anatomical logic comes in. Let's look at scenario A, gallstone disease.
Okay, so this is the patient who has had stones for years. They've probably had those attacks after a fatty meal, maybe some pain on and off.
Right. Gallstone disease is rarely a one-time event. It is chronic. It involves recurrent inflammation over time. We call it chronic cholecystitis. Think about what happens to tissue when it gets inflamed, then heals, then gets inflamed again, then heals again.
It scars. It gets tough.
Exactly. It undergoes fibrosis. The wall of the gallbladder thickens. It becomes tough and fibrous. Over years of this chronic abuse from the stones, the gallbladder becomes contracted and shrunken. It turns from a soft, elastic balloon into a stiff leather pouch.
Oh, I see. So it loses its stretchiness. It's not just about the blockage. It's about the container itself changing.
In medical terms, we say it loses its compliance. So let's say a stone finally moves and blocks the common bile duct, causing that jaundice. The pressure builds up behind the blockage. The bile wants to fill the gallbladder.
Right.
But because that gallbladder wall is scarred and fibrotic from 20 years of stones, it physically cannot distend. It refuses to stretch. So even though there is a blockage, the gallbladder stays small, shriveled, hidden under the liver, and impalpable.
That makes perfect sense. The history of the disease physically changes the container. The evidence of the stones is actually the absence of the lump.
Exact.
So if we flip the script, let's look at scenario B, malignancy. We're talking about something like carcinoma of the head of the pancreas.
Right. Now, contrast the timeline. In most cases of pancreatic cancer or distal bile duct cancer, the gallbladder was previously healthy. There hasn't been 20 years of inflammation and scarring. The organ is soft, thin-walled, and blue.
And the obstruction from the tumor, that's not sudden like a stone getting stuck, is
Oh,
it?
no, it's insidious. It
Mhm.
develops gradually. It's a slow squeeze on the bile duct. The tumor grows. It compresses the distal common bile duct. Bile starts to back up. The pressure increases day by day, week by week.
Oh,
But this time, the container, the gallbladder, is healthy. It's compliant. So what happens when you fill a healthy elastic balloon with water?
it expands. It keeps getting bigger.
It stretches, it distends, it becomes that smooth balloon-like mass that you can feel through the abdominal wall. And typically, because it's not an acute inflammation like an infection, it's just hydrostatic pressure, it's painless.
So that gives us the memory anchor from our source material, which I think is just brilliant in its simplicity. Stone scar. Cancer stretches.
That is the mantra. If you remember nothing else from this deep dive, remember that. It's a matter of tissue compliance. Stones scar the wall so it can't expand. Cancer blocks a healthy wall so it stretches.
It's amazing how much physics is actually involved in medicine. It's just fluid dynamics and material science. You have flow, resistance, and elasticity.
If we connect this to the bigger picture, it really is just plumbing. But it allows you to make a life or death distinction just with your fingertips.
I want to visualize this a bit more. We talked about what we feel, the palpable lump. But we have technology now. We aren't just relying on our hands like they did in 1890. If we look inside the body with an ultrasound or a CT scan, what does this logic look like on the screen?
It confirms exactly what we just reasoned out. If you put an ultrasound probe on that patient with a palpable mass, you will see a distended gallbladder. And you'll notice the wall is very thin, less than 3 or 4 millimeters usually. It looks like a tense, fluid-filled sac. It takes up a lot of real estate on the screen.
And because the blockage is downstream, I assume the pipes upstream are backed up too, like a traffic jam.
Yes. You will see dilated intrahepatic biliary radicals. Those are the small bile ducts inside the liver. Normally, you can't even see them on ultrasound. But here, they look like spider webs or little tree branches filled with fluid, and the common bile duct itself will be wide, like a highway. The whole system is pressurized.
And then if we move to the CT scan, that's where we go hunting for the cause.
The CT is the truth machine here. You trace that dilated common bile duct all the way down past the liver, past the gallbladder connection, and often, right at the head of the pancreas, you find the culprit. A mass compressing the distal CBD. That's the moment the anatomy exam turns into a diagnosis.
Speaking of imaging, our source mentioned something called the double duct sign. Does that fit in here?
It fits perfectly. We mentioned it briefly with the ultrasound, but it's really a classic CT or MRI finding. The double duct sign is when you see dilation of both the common bile duct and the pancreatic duct.
Two tubes dilated side by side, like a double-barreled shotgun.
Exactly. And if you think about the anatomy, those two ducts usually join together right before they enter the intestine at the ampulla. If both are backed up, mechanically, where does the blockage have to be?
It has to be at the junction, or right where they meet.
Right. It implies the blockage is at the pancreatic head or the ampulla itself. It strongly supports that diagnosis of a distal obstruction, usually malignancy.
Right.
It's the radiological cousin of Courvoisier's law.
It really all comes down to finding where the cork is in the bottle.
That's it. Medicine is often just looking for the cork.
Okay, so we have the law. Palpable gallbladder in a jaundiced patient means cancer, usually, because stones scar and cancer stretches. But there's always a but in medicine.
Always. Biology hates absolute rules.
To be a true expert, to have that consultant-level knowledge we promised, you have to know when the rules fail. You have to know the exceptions, because if you blindly follow the rule, you might hurt someone.
That's right. A student memorizes the rule. A master knows the exceptions. And there are specific scenarios where Courvoisier's law breaks. We can divide them into two categories. First, let's look at when stones decide to act like cancer.
So this is type 1. Stones mimicking malignancy. This is the false alarm scenario. How does a stone, which is supposed to scar and shrink the gallbladder, end up causing a big distended one?
It usually involves a bit of bad luck and mechanical complexity. The first scenario is the double obstruction.
Two stones.
Two stones, two different jobs. Imagine a patient has a stone stuck in Hartmann's pouch. That's the neck of the gallbladder trapping fluid inside. And they have a second stone blocking the common bile duct.
Oh, wow. So the stone in the neck turns the gallbladder into a closed balloon, making it big, and the stone in the duct causes the jaundice.
Exactly. It's a double hit. The jaundice comes from the CBD stone, but the palpable mass comes from the gallbladder stone trapping mucus. It mimics the clinical sign of cancer perfectly. Big gallbladder, yellow skin, but it's benign.
That's tricky. What else?
Similar to that is a mucocele. This is where a stone blocks the cystic duct, the exit of the gallbladder. The gallbladder keeps producing mucus, but it can't get out. It swells up huge.
But Mucocele alone doesn't cause jaundice, right? Because the main bile duct is still open.
Correct. But if that large, swollen gallbladder pushes physically against the common bile duct from the outside, something called Mucocele syndrome, or if they just happen to pass another stone, you get the jaundice. So you have a benign cause mimicking the malignant sign.
So in these cases, the law is technically broken, but the logic still holds. Something is mechanically blocking the exit, causing the stretch.
Correct. And the third stone exception is the large ampullary stone. The ampulla is the very exit point where the bile duct enters the intestine. If a stone gets stuck there, it obstructs the entire system. Now, if the gallbladder happened to be relatively healthy before this acute event, maybe they didn't have years of scarring yet, maybe this is their first big attack, it might distend.
So stone scar is generally true, but if a stone causes a sudden total blockage in a healthy person, stones can stretch too.
Precisely. It's rare, but it happens. These are the mechanical nuances. Compliance is a spectrum, not a binary switch.
Okay, let's flip it. We talked about stones acting like cancer. What about cancer acting like stones? Or rather, when do we have malignancy? But the Courvoisier sign is absent. The reverse exceptions.
This is just as important, maybe more so, because you don't want to miss a cancer diagnosis just because you can't feel the gallbladder. The most obvious one is simpler than you think.
The missing organ.
Right, the post-cholecystectomy patient. If the patient had their gallbladder removed 10 years ago, you obviously aren't going to palpate it no matter how big the pancreatic tumor is.
That seems obvious, but I bet it gets overlooked in the heat of the moment. You're feeling for a mass, you don't feel one, and you think, oh good, maybe not cancer.
Yeah.
But they just don't have a gallbladder.
Exactly. You have to check the history, check the surgical scars on the abdomen. Don't rely on palpation if there's nothing to palpate.
The second reverse exception connects back to our stone scar rule, doesn't it?
It does. Imagine a patient who has had gallstones for 20 years. Their gallbladder is a shriveled, fibrotic prune. Then, unfortunately, they develop pancreatic cancer.
Oh, I see. That's a double tragedy.
It is. The cancer causes the blockage, the pressure builds, but the gallbladder is too scarred from the past to stretch. So you have cancer, you have jaundice, but you have no palpable gallbladder.
So the history of stones masks the physical sign of the cancer.
Correct. The cancer is there, the obstruction is there, but the sign is absent because the history prevents the anatomy from reacting.
That is a crucial one. Just because you can't feel it doesn't mean the tumor isn't there.
And then there is the third one, which I find to be a moment of pure anatomical beauty, even though it's a terrible disease. The Klatskin tumor.
Parietal arc cholangiocarcinoma. This is the tumor of the bile ducts themselves, right?
Yes. But location is everything. A Klatskin tumor sits high up at the junction of the right and left hepatic ducts. This is above where the cystic duct, the line to the gallbladder, joins in.
Let me visualize the plumbing here. We have the liver up top producing bile. The bile flows down. The tumor blocks it right there, high up.
Right.
Then further down the pipe is the turnoff for the gallbladder.
Exactly. So if the blockage is high up, the bile never reaches the turnoff. The tap is turned off before the hose reaches the bucket. Bile never enters the gallbladder, so the gallbladder remains empty, flat, and collapsed. You have a patient with severe jaundice, a terrible malignancy, but absolutely no palpable gallbladder.
That is pure anatomy. If the block is above the inlet, the tank stays empty.
It raises an important question about how we interpret negative findings. The absence of a sign doesn't always prove safety, it just changes the differential. If they are jaundiced but the gallbladder is empty, the problem might be higher up in the liver.
This is fascinating. We've gone from a simple rule to complex fluid dynamics and anatomical plumbing. But let's bring it back to the bedside. So what? How does this change what a doctor actually does in the room with a patient?
This is where we transition from theory to triage logic. Courvoisier's sign isn't trivia for a pub quiz. It directs the immediate next step.
Okay, walk us through the roadmap. You are the consultant.
You have a patient, progressive painless jaundice. They've lost some weight. Maybe their appetite is gone. You palpate a smooth gallbladder. At this moment, you stop guessing. You do not treat for hepatitis. You do not just watch and wait.
What is the move?
The move is a contrast-enhanced CT of the abdomen, or a specialized MRI called an MRCP. You need to see the pancreas. You are evaluating for a pancreatic head mass, distal cholangiocarcinoma, or ampullary carcinoma.
And what are you looking for specifically on that scan, besides just, is there a mass?
You are looking for staging. You are looking for vascular involvement. Is the tumor wrapping around the superior mesenteric artery? Is it touching the portal vein?
Why does that matter?
Because that determines if it is resectable. Can we operate? Can we take it out? That is the only question that matters for long-term survival. The physical exam triggers the scan, and the scan answers the question of operability.
It sounds like the physical exam is the trigger for a very specific hunt.
It is. And while you are doing that, you might check tumor markers like CA19-9, but, and this is a key takeaway, CA19-9 is an adjunct. It is a helper.
It's not the boss.
It is not the boss. It can be elevated in benign conditions like cholangitis. It can be normal in some cancers. Do not hang your hat on the blood test. The anatomy and the imaging tell the truth.
So if I'm a young doctor and I feel that lump, I shouldn't wait for the CA19-9 to come back before calling radiology.
Absolutely not. The lump is the alarm. The blood work is just paperwork.
I really appreciate how this connects the physical sensation, the hand on the belly, to the high-tech imaging. It validates that the physical exam isn't obsolete.
Not at all. It's actually faster than the scan. In 10 seconds, your hand can tell you, this is likely malignant obstruction. That guides your urgency. It tells you to pick up the phone and call radiology now, not tomorrow.
It's about efficiency of thought, surgical thinking, as the text called it.
And it brings us back to that core concept, compliance. The body is constantly telling us its history through mechanical properties. A scar tells you about a past battle. A stretch tells you about a current siege.
I love that phrasing. A scar is a past battle. A stretch is a current siege. It really frames the pathology as a narrative.
That's what medicine is. It's just reading the story the body has written.
So let's wrap this up and summarize what we've unpacked today. We started with a patient with jaundice and a lump.
And we learned that this lump, this palpable gallbladder, signals that the obstruction is likely malignant, not stones.
Because stones scar. Chronic inflammation shrinks the organ so it can't stretch.
And cancer stretches. A gradual blockage in a healthy organ allows it to balloon out.
But we also have to be detectives about the exceptions. Stones can mimic cancer if they create a trap, like a double obstruction or a mucocele.
And cancer can hide if the gallbladder is already scarred, missing, or if the tumor is too high up, like the Klatskin tumor.
The application is clear? Don't guess. If you feel the sign, you order the CT. You look for the mass.
And you recognize that this is anatomy expressed clinically. It's not magic. It's compliance.
I love that word, compliance. It's usually a boring medical term, but here it's the whole story. The ability of the tissue to yield to pressure.
It defines the presentation.
And on that note, here's a final thought for you to chew on. We talked a lot about the gallbladder stretching or not stretching, but think about what that implies for other organs. This principle, function follows form, applies everywhere.
It really does.
Think about the heart. A heart that pumps against high blood pressure for years gets thick and stiff. It loses compliance. We call that diastolic dysfunction.
Or the lungs. In pulmonary fibrosis, the lungs scar and can't expand, compliance goes down. In emphysema, the tissue is destroyed and gets too loosey. Compliance goes up, but recoil goes down.
Exactly. The logic we use today, compliance dictates presentation, is universal. If stone scar and cancer stretches applies here, where else does scarring limits function apply in the body? The bladder, the arteries. The logic we use today works everywhere.
That is a profound way to look at pathology. The rules of physics don't change just because you move to a different organ system.
So next time you are learning a rule or a law in your field, don't just memorize the words. Look for the logic underneath. Look for the mechanics. Thanks for diving in with us.
Think anatomically. Think logically.
See you next time.